أدعو أستاذنا الأستاذ الدكتور شيرين وجيه ياسين أستاذ النيوكلير ميديسين كايرو يونيفرسيتي هيكلمنا عن الويل ديفرنشيتد ثايرويد كانسر ثيرانوستكس.
صباح الخير على حضراتكم جميعا، كل سنة وانتم طيبين. النهارده عيد تحرير سيناء. First of all, I would like to express my deepest thanks to the organizing committee and to Professor Dr. Ghada Al-Khatib for inviting me to attend the International Thyroid Egypt Conference. I appreciate so much her kind invitation. My presentation is titled Well-Differentiated Thyroid Cancer Theranostics. This is the flow of contents of my presentation. First, well-differentiated thyroid cancer. Since around 100 years, we classify thyroid cancer into two main types, which are well-differentiated thyroid cancer and undifferentiated type. The former represents around 90% of patients with thyroid cancer. This well-differentiated thyroid cancer has two main pathological forms, which are follicular and papillary thyroid cancer. The papillary type represents around 75 to 80% of cases. There is increase in the incidence of well-differentiated thyroid cancer over the last decades. In the year 2020, the number of cases approached 600,000 patients with a female-to-male ratio of around 3:1. This incidence expected to increase by around 30% in the year 2040. A well-differentiated thyroid cancer staging is unique in including age within the staging system. Also in the year 2009, the American Thyroid Association categorized well-differentiated thyroid cancer according to risk of recurrence into low risk, intermediate risk, and high risk, with some modification in this stratification in the year 2015. Some refinement of this stratification was done by two main methods. First, the addition of molecular risk stratification. Both together are named perioperative risk stratification. The second method is through updating risk throughout the clinical follow-up of patients. This is named also the dynamic risk stratification. Treatment of well-differentiated thyroid cancer is mainly in the form of total thyroidectomy and radioactive iodine therapy, followed by suppressive or replacement hormonal therapy. But despite best practice, recurrence rate was reported to occur in around 6 to 30% of patients, being higher in high-risk group. Also during follow-up, in 6 to 12% of patients with well-differentiated thyroid cancer, the lesions gradually lose iodine uptake ability, becoming more aggressive. This is known as dedifferentiation. This is due to various molecular mechanisms leading to decreased expression and or dysfunction of sodium iodide importers. There are different methods to treat recurrent well-differentiated thyroid cancer depending on the location, extent, differentiation, and ability to accumulate radioactive iodine. Now we come radioactive iodine. There are 37 isotopes of iodine. The one we take in our foods is iodine 127. All other isotopes are radioactive. Those used in nuclear medicine are iodine 123, iodine 131, and iodine 124, all used for diagnosis due to emission of gamma rays. But the only one used for therapy is iodine 131 due to emission of beta particles, which are accused for its therapeutic effect. Now we come to diagnostic imaging. Diagnostic imaging of iodine is mainly in the form of iodine whole body scan, which is done usually post-operatively, post-iodine therapy, as well as needed during follow-up. We can see here this patient post-operatively whole body scan showed residual functional thyroid tissue in the neck. This is another patient post-ablation using radioactive iodine. There is successful complete ablation. While this patient during follow-up there is elevated serum thyroglobulin level. Iodine whole body scan showed loco-regional recurrence here, as well as bilateral pulmonary deposits. Also, some new scanners have CT component, so we can do what is known as SPECT CT for better localization of the lesions together with higher diagnostic performance. This is an example of this. Here in planar images, we can see two well-defined rounded areas of iodine avidity in the neck. You suggested that they may be in the thyroid bed or in the cervical lymph nodes, but SPECT CT here localized this lesion as bone metastatic lesion. The largest one is here seated in the second thoracic vertebra. Now we come to therapeutic radioactive iodine. This is used either for remnant ablation of normal thyroid tissue, adjuvant treatment for suspected microscopic lesions, or treatment of known disease or macroscopic lesions. The dose of radioactive iodine depends on the aim of therapy, with larger doses for those with macroscopic disease. We can see here this patient post-operatively has big residual thyroid tissue in the neck. 1 year post-ablation, there is successful complete ablation. This is another patient with recurrent well-differentiated thyroid cancer in the neck with bilateral pulmonary deposits, received several doses of radioactive iodine with the final aim of he achieved complete remission here. But in patient with dedifferentiation, conventional imaging here saw left cervical lymph nodes, they did not accumulate any radioactive iodine. Now we come to theranostics. The term theranostic is a combination of the term therapeutics and diagnostics. This term was coined in the year 1998. Simply, theranostic point to the use of two radiopharmaceutical agents together are named as theranostic pairs, one for imaging and the other for therapy. The most important thing that they are going to the same target in tumor cells. So in theranostics, we treat what we see at the molecular level. This is shown here. This patient with malignancy, we can do imaging, which is diagnostic molecular imaging. If there is extensive expression of the target during imaging, you can give targeted therapy, then doing follow-up therapy, again, doing follow-up imaging again. You either give another dose of treatment, or if there is complete remission, just for follow-up. So if you have all these patients having the same malignant process, you can select properly who, with this diagnostic imaging, who are going to benefit from your targeted therapy and exclude them, exclude others to take other conventional therapeutic modalities. As a matter of fact, both diagnostic and therapeutic radiopharmaceuticals have the same structure, which is named the same vector. Apart from during imaging, you put radionuclide, which emit gamma rays just for imaging, while for therapy, you use radionuclide emitting particles, either alpha or beta particles for therapy, but both attached to the same ligand to be attached specifically and tightly to the receptor on the tumor cells. The most recent and successful examples of theranostics are targeting somatostatin receptors in neuroendocrine tumors and targeting prostatic-specific membrane antigens in prostatic cancer. Both were FDA approved in the last few years. This is expressed here very nicely in this patient with metastatic neuroendocrine tumors. You can see here multiple metastatic lesions all over the skeleton, seen by gallium dotatate. This means that there is significant expression of the targets here. So on receiving lutetium dotatate, lutetium is a beta emitter like iodine. In receiving 4 cycles of lutetium, there is almost complete regression of this metastatic lesion in patients with neuroendocrine tumors. Another example in patients with prostatic cancer here, for gallium plasma or prostatic-specific membrane antigen, there are many metastatic widespread skeletal deposits. This showing expressing properly the plasma receptor, but this patient did not respond properly to chemotherapy. He received only 2 cycles of lutetium with almost complete remission and significant regression of the PSA level. This success opened the door for many research studies trying to use many new ligands in the form either antibodies, antibody fragments, small molecules, new peptides, or even nanoparticles, targeting different targets either on cancer cells or in tumor microenvironment using different isotopes. Also, there is AI application in the field of theranostics. Many studies in the last few years were published about the use of theranostics in malignant lesions. There is continuous increase in the number of published papers over the years associated with increase in the global theranostic market. Also expected in the next decade or in the next coming year, there is expected high third wave of theranostic growth. Some authors name this theranostics tsunami, with expected increase in the market size of theranostics approaching $600.5 billion by the year 2031. Now we come to theranostics in well-differentiated thyroid cancer. Retrospectively, we can say that radioactive iodine is the most prominent and the oldest application of theranostics, going to the target which is sodium iodide symporter. either for benign condition as in patient with grave disease or in patient with differentiated thyroid cancer. Simply, radioactive iodine, you can give a small dose for imaging, then you can give higher doses for therapy and do follow-up post-therapy within 6 months to 12 months for assessment of response. So iodine is the oldest known example of theranostics. We can see this patient during imaging some osseous deposits in patients with well-differentiated thyroid cancer. Giving high dose, we can see that more lesions are here, can be seen, more metastatic osseous lesions with more intense tracer uptake, expected good response to therapy. This is another patient with recurrent leukoregional recurrent well-differentiated thyroid cancer with significant or multiple bilateral pulmonary deposits following multiple doses of radioactive iodine. There is complete remission. This marvelous success of radioactive iodine in treatment, in treating thousands of patients over each year, over decades, make it the first and the most successful known theranostic agent. So the first theranostic administration of radioiodine in patients with Graves' disease was given by Dr. Hurst in 31 of March, which was assigned at the World's Theranostic Day. Now we come to theranostic in dedifferentiated thyroid cancer. In dedifferentiated thyroid cancer, those patients are named patients with TENIS syndrome, which is thyroglobulin elevated with negative iodine scan. In those patients, there will be significant depletion of sodium iodide importers on the cell membrane, associated in the same time with increase in glucose transporter in the cell membrane. This is known as flip-flop phenomena. So you can see in this red box a patient with elevated thyroglobulin level, but yet radioactive iodine scanning is completely negative. If we do this with fluorodeoxyglucose or PET-CT or FDG, you can see significant increase in tracer uptake in metastatic lesions. So FDG has superior detection rate due to differentiation and high-grade tumors. So in patients with differentiated thyroid cancer, theranostics can help in 3 patterns. FDG PET-CT first, then to apply new targets and new theranostics pair, and finally by dual targeting theranostics. In the year 2014, this paper found that the FDG has very high sensitivity and specificity for detection of recurrence of this patient with TENIS syndrome, stating that this is a very valuable tool to predict occurrence of recurrent disease, and the detection rate or the diagnostic performance is increased with increasing serum thyroglobulin level. In the year 2024 also, it was reported that FDG PET-CT remains central in the detection of disease recurrence in patients with TENIS syndrome. This is very nicely expressed here. You can see iodine whole body scan is completely negative, yet thyroglobulin is significantly elevated. While performing FDG PET-CT, there are multiple bilateral pulmonary deposit, left cerebellar deposit, as well as right renal lesion seen in SPECT-CT also, in PET-CT also. Another patient with negative iodine whole body scan, there is a big recurrent lesion in the neck as well as bilateral pulmonary deposits well delineated in FDG scanning. This is also another patient with the same negative iodine whole body scan with bilateral in FDG showing bilateral pulmonary deposit mediastinum. Also you can see here there is also pleural deposit, which is a worse or prognostic sign. This is an Egyptian patient published in 2022 on 52 patients with TENIS syndrome, showing high sensitivity and specificity, with the final conclusion that FDG PET-CT provides additional information to establish proper therapeutic strategy for those patients with TENIS syndrome, achieving the concept of precision medicine. Now the second thing for differentiated cancer is to use new targets with novel theranostic pairs. These targets are seated either on tumor cells, on tumor vasculature, or on tumor microenvironment. New tracers here, the first novel theranostic approach is targeting tumor somatostatin or prostatic specific membrane antigen, but yet diagnostic imaging is has lower diagnostic performance compared to FDG, mainly due to heterogeneous tracer expression by the tumor cells. Here we can see in the FDG there is pulmonary lesion not accumulating gallium dotatate for imaging, so these are not so promising in those group of patients. A second new theranostic approach can be achieved by targeting integrins on the tumor cells with radiolabeled peptides. We can see here this is a very negative, completely negative iodine whole body scan, while targeting integrins show intense tracer uptake in recurrent lesion in the thyroid bed as well as lytic lesion seen here in CT in the sternum. So it was reported that targeting integrins has similar sensitivity but higher specificity and accuracy compared to FDG PET-CT. A third theranostic approach is targeting fibroblasts in the tumor microenvironment using radiolabeled fibroblast protein inhibitors here. These are very nice imaging. FDG PET showing some lesion yet using gallium-68 FAPI PET CT revealed more lesions with more intense tracer uptake in this metastatic lesion, and with the final conclusion that gallium FAPI PET CT has higher sensitivity than FDG in detection of local recurrence and distant metastatic lesions. It was concluded that FAPI agents represent a sensitive and valid alternative to traditional iodine scan and FDG PET CT. So in summary, for these new targets, targeting integrin and fibroblast have the most promising theranostic role suitable for routine application in patients with TENIS syndrome. Finally, for those with TENIS syndrome, there is a new method named dual targeting theranostics. The idea of this is to use theranostic pair going to more than one target. In this paper in 2024, the targets are going to both somatostatin and the integrins. This trial stated that the diagnostic performance is not inferior to PET-CT FDG in detecting lymph node, lung, and bone metastatic lesions. This can be seen here with negative iodine whole body scan, yet targeting going to two targets revealed intense uptake in right cervical lymph node as well as right axillary metastatic lesion. Finally, for those with TENIS syndrome, still FDG PET-CT remains central in the detection of disease recurrence in those patients, while novel radiopharmaceuticals open new theranostic perspectives to guide the proper therapeutic strategy for those patients. Now we come theranostics in redifferentiation. For those with redifferentiation or with TENIS syndrome, you can give redifferentiation therapy. This redifferentiation therapy means to reprogram the tumor cells in those patients to regain its differentiation and, most importantly, to restore theranostics power of radioactive iodine. So in this particular patient, radioactive iodine whole body scan first was negative with elevated serum thyroglobulin level. On receiving redifferentiation therapy, multiple bilateral pulmonary metastatic lesion and with L-osseous lesion were there. Also, this is another patient with negative iodine whole body scan. Conventional imaging show left pulmonary deposit, left pleural deposits. Post redifferentiation, there is intense uptake in this metastatic lesion in planar images as well as in PET-CT images here and SPECT-CT images here. Another patient with a baseline iodine whole body scan was completely negative, and a post-redifferentiation therapy there is uptake in bilateral pulmonary deposits with more intense tracer uptake on giving therapy. But this redifferentiation therapy is not always successful. The range of success range from 30%, 60%. This particular patient received redifferentiation therapy, but unfortunately there is increase in the size of the lesion and the intense tracer uptake in FDG, and still keeping radioactive iodine scan is negative. This is a proposed theranostic paradigm for advanced or recurrent thyroid cancer patients using dual tracer imaging. If we can image first using radioactive iodine and FDG. If the radioactive iodine is positive and FDG is negative, you can give radioactive iodine therapy. While if it is the reverse with negative iodine and active FDG uptake, you can go to another types of therapy. While if both are negative, you can go to use the novel theranostic approaches. Now we come to what are the future perspectives in well-differentiated thyroid cancer theranostics. We can look for new tumor targets in thyroid cancer cells or in the microenvironment, new theranostic probes. We can use dual targeting theranostics. We can use more successful redifferentiation therapy together with application of theranostic risk stratification and application of artificial intelligence, including radiomics and texture analysis. Now we come to the take-home message. We conclude that radioactive iodine remains the gold standard in well-differentiated thyroid cancer theranostics, either initially or post-redifferentiation. We can state that FDG PET-CT is the key theranostic player in patients with TENIS syndrome. New theranostic agents are emerging with promising results in those with dedifferentiation. Future perspectives include looking for new targets, new theranostic probes, application of AI. Theranostic risk stratification will refine personalized treatment strategies, improving outcome and minimizing toxicity. And finally, we can say that theranostics is revolutioning thyroid cancer management. Thank you.